Hello, everyone. Welcome. Welcome. I want to invite everyone to just relax and settle in. We're going to do a bit of I think we're going to call this a PhD class in malaria, because we have such wonderful speakers with us today. So, as you can see, this is about the ongoing fight to free 1 billion women from the burden of malaria. And we're very fortunate to have a panel of people who work on the ground, who work on the front lines, who have experience, whether that's in the lab or in the community, of what the specific things that can be done to address this global challenge. Before we start, I'd like to ask Dr. Shane Green, Director General, Development and Innovation of Grand Challenges Canada, to come and give a bit of a welcome to Canada and to the topic. Shane.
Afternoon, everyone. I'd say welcome to Canada. I'm used to saying welcome to Toronto. Right now, I'd say welcome to Toronto, home of the Raptors, but we're in Vancouver, so still, home of the Raptors, right? We're all in this together. So good afternoon, welcome to Women Deliver. I am Shane Green. I have the honor to welcome you here today on behalf of Grand Challenges Canada. I'll explain to you why that is. But who is Grand Challenges Canada? So we're an innovation platform. We exist to seed and transition to scale social, scientific, and business innovation for sustainable impact, in particular to save and improve lives of populations in low and middle income countries and among Indigenous peoples in Canada. I have the privilege of overseeing all of our work in the global health and development space through a variety of programs funded primarily by the Government of Canada, specifically Global Affairs Canada, and a growing list of other partners. So we fund innovators, including some present today, from low and middle income countries and Canada through a mix of grant and repayable financing, investing with a strong focus on gender equality and applying a mix of public and private approaches to evaluating impact, managing risk and knowledge, and ensuring affordable access to the outputs of the innovations we support. Since we were launched in 2010, we've supported more than 1,100 different innovations being implemented in 95 countries. We have an active portfolio of more than 400 innovations in maternal, newborn, and child health, of which malaria is a significant part. We have historically funded some 49 innovations specifically focused in the malaria space, and we'll hear about one of the really exciting ones very shortly. So why malaria? I don't need to tell you this, but I'm going to anyway, because that's part of my job. It's a truly global grand challenge. I mean, in a word. It's got complex gendered risk factors and impacts that make it really ripe for innovative, scalable approaches with a focus on gender equality. In spite of significant gains made in the fight against malaria, there are still more than 200 million cases worldwide, 435,000 deaths, with pregnant women and children under 5 bearing a disproportionate burden. 125 million pregnant women are at risk of malaria every year. Pregnant women with malaria have an increased risk of loss, of stillbirth, of premature delivery, and low birth weight infants, the consequences of which include the preventable deaths of some 200,000 babies and 10,000 mothers annually. Gender norms, socioeconomic dynamics, and inequalities in malaria endemic regions affect not only the risk of infection, but also access to services, prevention and control interventions, and place greater caregiving burden on women, limiting opportunities and empowerment through schooling, workforce participation, and community activities. We at Grand Challenges Canada are really proud to partner with Medicines for Malaria Ventures, MMV, to support bold new approaches for addressing malaria. Both GCC and MMV demonstrate leadership through a focus on setting goals around a defined challenge, a focus on impact, leveraging investments to maximize value for money, all with a strong commitment to ensuring access and equity. Later this year, MMV is going to celebrate its 20th anniversary, which I think is very exciting for the field, over which its unique PDP, Product Development Partnership model, has made it a global leader in anti-malarial development. structured as a PDV to develop innovative, affordable medicines and tools for populations affected by poverty-related and neglected tropical diseases. MMV takes a portfolio approach to research and development to accelerate product development, pursuing multiple strategies for a disease area. The most promising products then get to move forward. And you can get just a glimpse here of what a pipeline looks like 20 years ago and today, and the dramatic impact that MMV and partners have had in the space. You don't need to be able to read the particulars to come away with a real sense of the scope of impact MMV is having. One such promising, innovative approach is the Mamas Against Malaria Project, and we're going to hear about that today. This is implemented by Development Data Zambia with support from MMV, Grand Challenges Canada, Transaid, and other partners. It's an innovative approach to increasing access to pre-referral rectal artesunate, a life-saving drug administered immediately upon diagnosis to prevent progression of severe malaria in young children during transfer to tertiary care centers. Now, rather than steal their thunder, I'm just going to end by saying we're very excited to be able to contribute to $500,000 in support of this exciting and innovative approach to improving access to a proven therapy, with strong government partnerships in place, and I know we'll hear more about that, and using gender-smart strategies and inclusive approaches in program design and delivery, which in turn promote gender equality and empowerment of women and girls. With that, I think, Valma, I'm going to pass it back to you to welcome the panel. Thanks very much.
Thank you very much, Shane. That's a wonderful opening. What I'm going to do now is I'm going to ask our panelists to come to the stage. I'm just going to say their names, and as we go to each presentation, I'll give you a little bit more about each of our speakers. So please, Joy Pumapi, Dr. Cokie Agarwal, Dr. Vivica Kosciusko, and Dr. Ruth Nyendra. Oh, Nirenda. Excuse me, please. I'll take this chair and I'll let you just move along. Sorry. And there you are. I'll move over one, too, sure. Joy Pumapi is the co-chair of the UN Secretary General's Independent Accountability Panel for Every Woman, Every Child, Every Adolescent, and Executive Secretary of the African Leaders Malaria Alliance. Madam Pumapi is currently the Executive Secretary of the African Leaders Malaria Alliance, an alliance of 49 African heads of state and government. She also serves as co-chair of the Independent Expert Advisory Group for Every Woman and Every Child. She has served as a member of the UN Reference Group on Economics, as a UN Commissioner on HIV, AIDS, and governance. She also sits on the board of several international nonprofits in global health, including CIFF, Children's Investment Fund Foundation, African Comprehensive HIV/AIDS Partnership, Medicines for Malaria Venture, Rollback Malaria Partnership, and as an advisor for Hilleman Laboratories and the Gates Foundation Malaria Program and the Harvard Health Ministerial Leadership Program. That's quite a list, isn't it? Do you have time to do anything else? Joy, I'm going to ask you to lead off the panel. Thank you.
Thank you so much. I'm really honored to be here this afternoon, and to speak to you about women and malaria. Why eradicating malaria is so important, and why is it a very effective tool of empowerment for women. Malaria has often been described as a disease of poverty. It's known for dramatically raising household expenditures, as you have already heard, as it reduces income through lost production and absenteeism. It drags families and communities into poverty that is made generational by children's lost learning potential and subsequently lost earning potential. Indeed, its devastation is so great that the Copenhagen Consensus Group estimates that for every dollar invested in malaria, the rate of return is $36 US. What we do not often hear, however, is that malaria has a female face. We heard a little bit earlier on about what this female face is. But what we should also appreciate is that over 90% of all the people who contract malaria each year are either female or are taken care of by women. So it is not just about the 125 million pregnancies at risk and the 200,000 babies that we lose and the 10,000 mothers whose lives are also lost to a preventable disease. It is about the fact that malaria inhibits the productivity of women. And it is about the fact that it stops them from taking care of their families, and it arrests development. We know that more often than not, babies that do survive are born with low birth weight, associated with ill health, which is associated with ill health, with poor cognitive development and stunting. Their future is therefore compromised right from the beginning, even before they can overcome other social and environmental challenges that we are all familiar with. And therefore, they are a cause of a constant worry and trauma to the mother. But I believe with malaria, it is not just about illness, care, and pregnancy. Women are the face of malaria because the sector most affected by malaria is the agricultural sector, particularly the subsistence farmers. Most of the workers in this sector are women. Indeed, research demonstrates that women produce 80% of all food produced on this planet. Yet they own less than 2% of the land and receive less than 10% of agricultural assistance that is offered by governments. So what it means is that the women who produce all our food are the poorest citizens of this planet. We all know that poor nutrition is a major driver of disease and infection. So when malaria inhibits production levels, food production levels in these communities, poor nutrition is a result, and therefore it is not only the infectious disease of malaria that is going to infect the under fives and members of these women's households, but it is a lot of other opportunistic infections as well that are going to infect the family as a result of undernutrition or poor nutrition. As a result, the majority of these women are trapped in poverty, and the poverty reduces the harvest, as I said earlier, increases household expenditure, and most of which are made out of pocket. We are here today because MMV wants to share with us their 20-year-old commitment of being effective. They define this effectiveness as the ability to discover, to develop, and to deliver new, affordable, efficacious anti-malarials through dynamic PDPs, as you have heard earlier, whilst meeting expectations of safety, speed, cost effectiveness that women demand and deserve. This is a tall order. But like the women that MMV seeks to serve, MMV is driven by an abiding passion for people. The most passionate human beings about people on the planet are women. I apologize to the men, but it is a fact. And it is this passion for people that drives the thrill and opportunity of innovation and the added value of working together in partnerships. I believe the presence of MMV at Women Deliver gives women of the world an opportunity to engage with a partner that wants to break down barriers, to explore new ways of using the existing tools, as well as finding new tools. Since contracting malaria in pregnancy can have terrible adverse consequences for both the mother and the infant, as you already know, by increasing the risk of anemia in pregnant women, it is the single most preventable cause of low birth weight, which, as you know, is associated with high infant mortality. So the question that MMV is asking women today is, why not focus on making preventative measures such as chemoprophylaxis and insecticide-treated nets available to all teenage girls, all women, irrespective of age, irrespective of parity. Given this urgent need for the right antimalarials, I believe the offer that MMV is making to women today is that join MMV to press hard to develop new and distinct antimalarials that are suitable for pregnant women for both prevention and for treatment. Though their development is challenging, MMV, I believe, is here today because it believes in the power of women who are inspiring and challenging us all with their power. We are living in the people's century. That is the commitment that we made in 2000 and that we reinforced in 2015 when we came up with the SDGs. It is a period when we have collectively agreed once and for all to walk the talk of health for all. We said that health is a human right. We said that universal health coverage challenges us to make this a reality. And we say that we will not leave half the sky behind. That is the women who are here. I believe, as a board member of MMV, that MMV believes that universal access to affordable antimalarials is a fundamental right. And that in order to actualize this agenda of leaving no one behind, no woman or no girl behind, though we still have a long way to go, we can get there. The 2018 World Malaria Report states that only 29% of under 5-year-old children who need treatment received antimalarials in 2017. 29%. WHO data from 2016 gives malaria as the 5th major cause of death amongst girls between the ages of 10 and 16 years. I believe that adapting antimalarials to these vulnerable groups, women and adolescents, is a must. I would like to urge partners to call for indicators on universal health coverage that adequately assess progress on meeting the specific needs of women and girls, including access to antimalarials, both for prevention and for treatment. I believe it is a rather serious indictment on our values as a human family that we have to include women of childbearing age, children and adolescents amongst the neglected. The question is, if they are neglected, then whom are we focusing on? We are aware of the African proverb that says, if you want to go far, you must go together. So I appeal to everybody to go together with MMV. Let us travel this path together. The road to universal health coverage is not easy, but Mandela has said it always seems impossible until it is done. And I believe with the support of MMV and the support of the women of this planet, MMV will deliver the antimalarials to women, and MMV will make sure that universal health coverage walks the talk. Thank you.
Well, there's a wonderful start to this, a little cri de coeur. I think it's the proverb of always going together. I think it's always very wise, and certainly a value of so many women that I know who work on this issue and so many others. Thank you, Joy. Now we're going to hear from Dr. Cokie Agarwal, Director, USAID's flagship maternal and child survival program. Dr. Agarwal is an internationally recognized expert in safe motherhood, reproductive health, and family planning policies and programs, as well as promoting policy dialogue and advocacy for policy reform. She has more than 25 years of service delivery experience in reproductive health, family planning, maternal health, and for over 2 decades has led, managed, and implemented large-scale USAID-funded global health projects. Remember, I told you we were talking to people who work on the front line. Since 2014, Dr. Agarwal has directed USAID's flagship maternal and child survival program with a focus in 24 USAID priority countries. Dr. Agarwal.
Thank you so much. It's a really proud privilege to be able to talk today and present some of the work that we've been doing in malaria and why it is important to solve this issue for women and children of the world. So I wanted to talk a little bit about other presenters have talked a little bit about the global burden, but I wanted to reiterate because I think every time I hear the statistics, I just wonder why we haven't been able to do more and do more faster to solve this problem. So we know that pregnant women and children face the burden of malaria, and as Joy said, it's becoming the face malaria is becoming the face of women. It's not, we see that in every country that we work in. And I think the other issue is that we still see a lot of young children under 5 dying from malaria. Almost every 30 seconds we lose a child from malaria, and this is really not acceptable in today's world. So while we have reduced the child mortality in the last few decades, we haven't seen the progress that we want to see in reducing the malaria burden. If we look at the graph of the number of deaths from malaria, we see that in 2000, we almost lost over 800,000, 840,000 women and children from malaria. And if you see now in 2017, I think it's over 430,000. So we have made great strides in terms of halving the number of deaths, but you can still see that the biggest burden is borne by Africa. And we've been talking a little bit up till now about the burden borne by the African women. So in terms of the work that JPIGO and MCSP has done is across the MCSP malaria programs, whether it's working on malaria and pregnancy, case management, and malaria elimination in different countries. And we are part of different groups, the RBM working group, as well as looking at ICCM task force. And we've been trying to see how we can support the efforts, global efforts in making malaria and pregnancy and childhood malaria not such a big issue. So at this point, even now, as Shane said, 125 million pregnancies occur in the region where the transmission of falciparum is still high. And we lose 10,000 women from malaria every year. Newborn mortality is 100,000 deaths per year. We also see that a burden that nobody talks much about is the stillbirths because they're not really measured in most cases. 8% stillbirths globally from malaria, and 20% of the stillbirths that we see in Africa are coming from malaria. Malaria also contributes to the morbidity and the other infections like issues like anemia, low birth weight in infants, and infant deaths. So we know that it's some infection that creates multiple issues for both women and children in their most vulnerable times. So why is it so important to address malaria and pregnancy? Because during pregnancy, women are immunosuppressed and they have a higher risk of acquiring infections. So we need to make sure that they're supported and not exposed to the infection. The infection also in stable transmission areas, we know that women may not exhibit the full signs of an infection. So it's hard to recognize that they have a malaria infection that needs to be treated. And we know that as women have number of children, with the second child onward, they have lower risk. But if they have concomitant infections like HIV, then the risk of their acquiring infections is high, remains high. So we know that many African women bear the burden of not only acquiring malaria, but also HIV and TB, and that exposes their, makes their risk even higher. I think we have straightforward guidelines from WHO that very clearly articulate what we must do to address malaria in pregnancy. We need to make sure that they sleep under a net as early in pregnancy or before if possible, and we promptly diagnose and manage any infection of malaria during their pregnancy, and we give intermittent preventive therapy, IPTP with sulfadoxine pyrimethamine. Which is starting in this now with the changed guidelines from WHO, starting as early as possible in the second trimester and giving at least 3 doses. And it was a great decision to deliver through an existing platform like antenatal care, which we know that almost 70% of women will make at least one antenatal care visit. But yet we see that the number of women receiving IPTP3 has not increased and has not gone to the levels that we need to see. So while we know that we know what we need to do to prevent malaria in pregnancy, we know that IPTSP works. It reduces low birth weight. It has an impact on the maternal anemia. It reduces the perinatal mortality. And it's highly cost effective. 1 tablet costs only 0.06 and we need to give 3. So it's a very cost effective medicine. But we still see that the rates are not high enough during antenatal care. So we need to ensure that we are looking at a comprehensive package and looking at a systems approach to deliver this medicine, even though we know it's being delivered during antenatal care, looking at policies and strategies, ensuring effective financing, ensuring commodities and supplies at the point of care, and ensuring that there's leadership and measurement of what we are giving out to women. So one of the areas that we, given the challenge that women don't receive IPTP during antenatal care, we've been thinking through during this RBM working group and the work that JPIGO and MCSP has done, what is it that we can do to make sure that women can receive the SP that they deserve and higher number of doses of SP during their pregnancy. And one opportunity that we have is to see if we can deliver it through a community-based approach. And we are really excited about this project that I'm going to talk a little bit about, the TipTop project, which is supported by United, and WHO, MMV, and IS Global are all partners on making sure that we can deliver and demonstrate a pilot as well as scale up in 4 countries the delivery of IPTP-SP through a community-based approach. And we hope that this can then be utilized in guidance that WHO will develop to change their guidance to expand the scope of delivering IPTP-SP through not just the antenatal care, but also through a community-based approach. So you can see here, this is that part, I mentioned the TipTop project, and you can see here the graph, the charts in the blue shows that we are increasing the delivery of IPTP in the community-based approach. But we also want to make sure that women are not avoiding antenatal care, not going to the facility as we expand their delivery through the community. So we are also trying to measure that they are continuing to attend antenatal care visit. And as a matter of fact, we are trying to make sure that we ensure that they attend antenatal care visits, not only the numbers, but also early in the pregnancy. So you can see both have increased, and it's a very positive sign that we can see more women being reached by this community-based approach. We also have another project that is supported by the USAID's President's Malaria Initiative in Burkina Faso, looking at the community-based delivery of IPTP in 2 districts. And this is also a trial that we are looking at. How do we make sure that we deliver IPTP3 and see the increases in rates of IPTP3 uptake and 4 uptake? And we see here in the graph over here that you see that IPTP4 uptake in the intervention area, which is the yellow bar up there, is really almost double of what we saw in the control area. So we've been able to, through this community-based mechanism of delivering IPTP, through training community health workers, making sure that they have the commodities and have the supplies, will ensure that women can get the numbers of doses, the sufficient number of doses, at least 3 doses, if not more, during their pregnancy. And we also try to encourage them to come early in pregnancy, and that's another indicator that we are trying to measure. So through these 2 studies, and I believe there are other studies going on, and PMI may be funding 2 additional studies in countries, we hope to generate enough evidence that we can use with WHO to change the policy guidance so that we can disrupt the care that we have been seeing, the lack of progress in IPTP uptake in antenatal care, so that we can provide this as a disruptive mechanism and make sure that women can get the services that they deserve. And I think the other aspect of this, as Joy was speaking about the role of MMV, I think it's really exciting because we want to see that they are creating the malaria drug that is easily dispersible at the community level, so that women can not only get it from the community health workers, but ultimately I think we need to make sure that women are empowered for self-care, and that's my personal goal. I don't know when it will be accomplished, but I'm hoping that we can also make sure that women feel empowered, that they can take it, they want to take it, they know when to take it, and they can be the caregivers for themselves. Another challenge, I think, for ensuring that we have effective case management is reaching children. As Joy said, only 29% of the children who should have gotten malaria treatment received care in 2017. So we need to build the capacity and see how we can not only build the capacity of the facilities that can diagnose malaria when it's and provide appropriate treatment as soon as they can. And we've been working in MCSP to develop performance standards that can be used to then measure how effectively the facilities are delivering the malaria care to the children who are coming. And we've been seeing, because of this assessment and quality of care, we've been seeing increases in the number of children who've been receiving care in Mozambique. Also there is already programs in many countries to reach children through integrated community case management of the 3 diseases, malaria, pneumonia, and diarrhea. And we see that that's an effective way of reaching more children, because they may not go to the facility, they may go to private sectors or small drug shops to get immediate care. And we need to make sure that the ICCM programs also deliver care, but we need to ensure that there's the right supplies and they have the stocks and they are able to provide the training. So MCSP has been working in ensuring ICCM care in many countries to reach the effective treatment for the 3 diseases, and we've been seeing some effective changes in DRC and other countries. I just wanted to highlight the barriers, and I hope we can talk a little bit about it, but there are still remaining barriers in terms of commodities, and we see inconsistent supplies. Even now, when we do data management, we look at SP rates, and as soon as there's commodity stockouts, we see the rates dipping. So we know that there's a challenge there, and why are we not able to have effective supplies at every facility that is seeing women or children with malaria? I think the issue of increased drug resistance, because we have very few drugs to rely on, that we have the issue of increased drug resistance, and we need to be able to monitor and be able to change if need be. And the lack of quality assured medicine, which I think is really important for MMV to continue to play a strong role in, and we are hoping that they will continue to do this for the TIP-TOP and other projects. Provider knowledge, I think sometimes is still a barrier. Understanding the guidelines and making sure that they are able to provide the SP, IPTP as soon as they can in the 2nd trimester. They could be provider biases about when they think it's appropriate to provide. Those are things that we need to still address. And early ANC is still a challenge, because we need to make sure that women come in early so that they can get the requisite doses during their pregnancy. We see women coming in very late, and then they're unable to get their 3 doses. So we need to ensure, and then some of these strategies that I described, the tip-top projects and others that are trying to reach women through community, increase their knowledge and understanding of why they need to come in and why this is important for them to take as a drug during pregnancy, is going to hopefully change the barriers. So I wanted to end there, but I think that it's important for us to continue to address this issue, and we know that we have effective treatment, and we just need to make sure that women are there, that we are able to provide women and children with this treatment at the right time for every person wherever they live. Thanks.
Thank you. Thank you, Dr. Agarwal. So now we're going to hear from another angle of the challenge. Dr. Vivica Kosciusko, PhD, VP, Head of Product Development, Medicines for Malaria Venture. So we heard a pitch for MMV, we heard support for MMV, now we're going to hear from MMV. So you're the head of product development based in Geneva. And as you heard earlier, I think we know here MMV is a public-private partnership with a mission to develop new, new effective and affordable medicines for malaria patients in endemic countries. You are responsible for late-stage development portfolio of anti-malarial drugs. Prior to joining MMV in 2012, and pursuing your interest in global health, I see that you spent more than 15 years in pharmaceutical industry working across all phases of drug development. You started your career in discovery research at Abbott Laboratories, then at Merck Serono in Geneva. You have a PhD in biochemistry from the University of Illinois and a bachelor degree in chemistry from the University of Chicago. So now we're going to hear a completely different perspective. Dr. Kosciusko.
Thank you very much for the introduction, as well as all the kind words about MMV's mission and work. You're certainly raising the expectations and the bar even higher, but that's a good thing because researchers are quite competitive by nature, so we need that stimulus, so keep it up. So, as was said, I'm going to take you in a slightly different direction, and that's probably because of my own background and where MMV is as a contributor to the overall fight against malaria. So I'd like to talk to you about malaria and pregnancy, but from drug development perspective. And I structured this 10 minutes in a very simple way. I'd like to state what the problem is, because I think even if it's obvious, it's often good to know what it is that we're trying to fix. I'll tell you a little bit about how difficult it is to develop new drugs of any kind, particularly for women, and then even more so for pregnant women. And most of all, it would be good to point out as I'm going along how I think we can improve and particularly do much better for pregnant women than we're doing today. So what is the problem? The problem in malaria, as I see it through my lens, is that we do not have enough data on safety of even existing antimalarials. And that leads to poor judgment and poor decision-making, probably, by women themselves and by their practitioners. So it's a big issue. Number two, the choices of malaria medicines that we have today for pregnant women are very limited. And three is that pregnant women are still being excluded from clinical trials. So we have a bit of a vicious cycle going. And the graphic on the bottom is just a reminder for everybody how long the road from the laboratory to patient uptake is. And I'm going to focus really just on the left-hand side on product development and a bit of the regulatory landscape to keep it simple. So we've heard this number already 3 times. I think if I counted properly, there are 125 million pregnancies at risk. And what my contribution to this statistics is that I asked somebody smart to pull out how many girls are affected. And 23 million. As a mother of 2 fantastic girls, I think that's shameful, that we cannot do better for them. And majority of these girls are age 15 to 19. 2 million are under 15 years of age before they become pregnant. And in Niger alone, 50% of women give birth before their 18th birthday. So it's a huge number. Last I looked up, it's close to the entire population of Australia. So why are pregnant women vulnerable? Well, Cokie explained already quite a bit, but from the perspective of drug development, we need to safeguard both the mother and the child. So the mother is at risk because many medicines do not work the same way in pregnancy as our metabolic state changes. So the doses of medicines need to be adjusted for pregnancy, and they're usually not. As for the child, many medicines might have an effect on the developing fetus, and then consequently on the life of the child when they're born. So it's really two beings that we're looking after. Now, turning our attention to what are the choices for pregnant women, where there are exactly one recommended by the WHO today, and particularly for first trimester pregnancy. And that is the most vulnerable part as we know, the fetus could be mostly affected during that stage. So what we have is one option, quinine and clindamycin, to treat malaria. We have really no options to prevent malaria during first trimester pregnancy. And interestingly, studies are just ongoing now with medicines that have been used for decades to treat malaria in the non-pregnant population. So we're doing much better, just not to leave you with this as a very bad picture. We're doing much better for second and third trimester pregnancy, where we can use the standard of care. But it's really that early stages of pregnancy that require most attention from safety perspective. So how do we start looking for new drugs, as they're clearly needed? Well, we start through animal studies, where there is a package of developmental and reproductive toxicology studies that are performed by according to our regulatory requirements. And typically, they're done right in sort of in sync with when you're going to introduce women in clinical trials. But what we're trying to do at MMV, with help of our partners, is to perform those studies as early as possible. Because in fact, if our target population are pregnant women, we'd like to avoid investing in clinical development of drugs that ultimately will be shown are not suitable for them. So it's a way of being smart about how we spend our money, but also being expeditious about our work, because as you know, it takes a very long time to develop drugs. As shown on this graphic, so drug development is a complicated process. It takes approximately, or minimum, I would say 10 years from the time we pass the laboratory stages, the preclinical stages, from phase 1 to phase 3 development. It is expensive. In malaria, it's about $100 million that need to be spent from beginning to end, and that does not include usually all the excess work that we will hear about next. And it's highly risky, because 95% of the chemical entities that start will actually fail. So because of this risky business, those who develop drugs tend to be quite conservative. And it used to be that only men were included in clinical trials. Well, that luckily changed more than a decade ago. So women are being included, but they have to take contraception, so they cannot become pregnant. And when they do become accidentally pregnant in trials, they're withdrawn, taken out for safety reasons. So consequently, we do not really have any data, typically, in pregnant women until the drug is registered, rolled out, for men and women, and in malaria, actually for children, which is already quite good. But that road to getting enough data in pregnant women is quite high and long. So MMV would like to ensure that we close that gap, and we're starting to introduce pregnant women, studies in pregnant women during phase 3 of development that is planned for future drugs that are in pipeline now. And we have a strong supporter in this from the regulatory perspective. So luckily, the US FDA in particular is responding to the need and is updating their guidance. So last year there was already an update on the inclusion of women in clinical trials, and this year we are starting to review and contribute to the guidance on lactating studies, which we haven't even touched upon here, which is also, of course, of great importance, and then these post-approval pregnancy studies. And as you can see from the dates, those updates were badly needed as they're over 10 years old. So to summarize, how can we improve on all of that? Well, from MMV's perspective, we're trying to adapt to the drug development strategies to include pregnant women as early as possible in a safe way. We ultimately would like to provide choices of safe medications, provide data for informed decision-making, therefore empowering women to look after themselves and to influence their practitioners. And certainly, we want to leave no pregnant woman behind. And I'd like to close with the quote that from a woman who I never met, and I hope to one day, who said that pregnant women should not be protected from research, but through research, particularly safe research for pregnant women. Thank you.
I'd like now we're going to the community front lines. Ruth Nyrenda, District Program Officer, Mamas Against Malaria at Scale. And I think the at scale is important, isn't it, Ruth? You are currently the District Program Officer for Mamas Against at Scale in Zambia, involved in the implementation and support of all project activities in Chitambo region, Central Province. Prior to Mamas at Scale, Ruth was a district program officer for More, mobilizing access to maternal health services in Zambia. She has worked in the health and community development sphere for a total of 8 years, and I think we're in for a treat with her presentation today. Thank you. Ruth.
Okay, firstly, I'd like to thank everyone, and I would love all of us to watch what is coming.
Okufuma obushiku bw'amayiro omwana alisa alwala omubiri we alisa akabasaana alisa afirwa n'okulya n'ebyakulya efa n'akiisa afika nakuli bakome kishinka bamupima n'omulopa bamusanga n'obulwere buntu bakimusanga nabo.
Severe malaria, if left untreated or unchecked, can result in death, especially within the first 24 hours. The majority of lives lost to malaria are those of children who live quite far from health services.
How do you save children who are living in remote communities who are suffering with severe malaria?
Here in Zambia, we're using an already existing form of anti-malaria treatment, artesunate. In this case, it's in the form of a rectal suppository. This is a life-saving form of drug. The initial dose allows time for the sick child be transported from the remote area that they're coming from to the health facility where they can access more treatment.
Zambia is a very big country with about 752,000 square kilometers. Some villages can be as far as 50 kilometers to a health facility. If you have to get the child to the health facility in time, there must be a transport system in place. So these bicycle ambulances are a much better mode of transport because they need to be transported in a very, very proper way so that you don't complicate the condition.
By the time they are reaching the health facility, at least they are stabilized. Now at the facility, we usually give injectable artesunate in order to complete the treatment.
Lero nakireeta omwana ku kipataala nakimuleeta n'okumundapa bamundapa n'omwenso nshikweto akwe batikutyawo nayika.
Since the introduction of this anti-malarial drug, we've seen a huge reduction of death in children under 5 in remote areas.
By improving access at community level, we can save more lives, which has been proven already in Zambia. Now that there's a World Health Organization quality-assured rectal attested suppository, this has the effect of improving our fight against malaria. Currently, 29 countries have introduced this form of treatment. This is one of many innovations that we need in the next 5 years in order to beat malaria.
Okay, thank you so much. I'm sure from the video you were able to note some of the interventions that are done at community level. Because where I come from, things are quite critical when a child has malaria, especially in terms of the mother that will look after that child. So initially when the project started, it was a pilot project, there were only a few facilities that were piloted on. There are only 8. And then there were only 45 communities in a district where we have thousands of communities, but only piloted on 45 of those. But currently, there was a scale-up. It's no wonder you saw that it's Mamas at Scale, because there's a scale-up project that is funded by Grand Challenges of Canada. And then we have 18 facilities. We have included 18 facilities under Serenge, where the video was done. But we also have other facilities there are 2 districts now. We have Chitambo. So in total, we've got 18 facilities that were added up across 109 communities. These communities are very far away from the facility. It may take hours for a mother to reach the facility to get the needed help. So by training the volunteers, we've noticed that the hours that a mother has to spend walking are at least being cut short in terms of when a child is given the rectal test on it. The child who was very sick and actually maybe had challenges in even eating, the child would at least get the strength and the mother would have the courage now to put the child on her back and come to the health facility. So the population there has increased as well as the facilities. Then the approach that we use as a project is not that of a classroom approach. Instead, what we use is we engage the community on a one-to-one discussion, or we sit in groups where even women who are affected by the malaria cases are present. From the picture, I'm sure you're able to see that this approach involves using the body too. Whereas you are facilitating or helping the community to understand certain topics on malaria, we are using our body. It is easy to remember than when you just talk about something. It will be quite difficult for this mother or this girl who has a child to remember. So it's no wonder from there we are able to demonstrate using the body and also the sing and do, where there are songs that come up that carry messages concerning severe malaria. You can see there, we have the community volunteers that are singing, maybe a song that has got a message on how a family or a community is able to identify a child with severe malaria. Then from the video, I'm sure you had seen on how community systems are helping in transferring children that have got severe malaria from home to the health facility. And these systems that we are seeing, it's a bicycle ambulance. This bicycle ambulance can be ridden in situations where a child with severe malaria case cannot be put on the back, especially one that is convulsing. It's quite difficult to carry because in Africa we carry mostly on our back. Now when you have a child that has convulsions, you can't carry. So the bicycle ambulance comes in to help this mother. She sits with the child and then the rider can be either male or female, and they are carrying this child to the health facility. One way is to help our mothers that have to walk long distances with a sick child. In some cases, even the mother might have malaria. Now the bicycle ambulance is helping our mothers there. And as you can see, there's women involvement. It's not just left to men to do the riding and everything. Women have come up. They are now more involved to try to eradicate malaria in the community because it's quite severe. And then a mother cannot do any other job if she's nursing 2 or more children that have got malaria. Those are access barriers, real access barriers. Even if you are to walk on that sand, you could have challenges. The bicycle ambulance there also has challenges. Now, in one way of addressing these access barriers is by trying to come up with ways of moving from one community to the other. But that challenge of accessibility is very high. It's no wonder the bicycle ambulance that we've mentioned earlier is suitable for such an environment. It is able to move so that we help our children and our mothers out there. From the experience, we've got one female rider by the name of Josephine there. As she's mentioned there, it's one of the best things that has happened in the community, because even though people are facing, or communities are facing malaria, they are able to use the bicycle ambulance. And then she goes about with other activities during the day. Even if she's passing in the community, it's a well-known thing. People use it. It's very important. It's actually one of the components that has brought the project together, because we may give a child RAS, you may have a mother there, but without transport. For some, I'm telling you, they can't go anywhere. And then that child would be very severe, because that's not a treatment, it's a pre-treatment for malaria. So that bicycle ambulance, as well as well-motivated mothers who are riders, are able to carry these children to the facility. And then I'm sure from the video also saw, when the project was piloted, there was that decrease in terms of child mortality, because from the 8 facilities, there was a decrease of about 0.2% of malaria deaths from 8%. It may look small, but it's huge. Just saving one child. I'll talk about one experience that I had. When we were in the community, because I work daily with these mothers, when we were in the community, though, I found a mother, she had tears in her eyes. I asked her what was the problem. She told me she couldn't believe what rectal artesunate had done to her child, because the child had really severe malaria. And then the child could not eat, the child could not breastfeed, and the child could not do any other thing because the child was so sick. And then when the rectal artesunate was given to this child, the child improved and even cried for food. So the mother was touched by what the drug had done to the child. So malaria indeed can be reduced if we could have such interventions at community level, now at a wider scale. These are fewer communities, but we've seen good results. If it could be rolled out to more facilities, or even the whole of Africa where we have severe malaria cases under children, then I believe we can even eradicate malaria, maybe in a few years' time. There is the story of my mother that had received rectal artesunate. So with the help of partners that we have, like Grand Challenges, Transaid, DI, Development Data, we have DISA-Care, MMV, we'd really love that we could receive more help to help these babies, because rectal artesunate is given to a child that is 6 months to 6 years. So we have a lot of these, because we have a lot of babies in the community, and it is able to save that life. So we could have more support to help our mothers, our young women there who have children, because we have young girls that have children, and these children are affected by malaria. So most innovations that come, or incentives that come in the community, rarely reach those that are socially excluded. But with the training of ICCM volunteers, or those that are able to give rectal artesunate, we've seen that the target usually goes to those that are socially excluded. If there are sick children in that family, those will be brought together. They'll be like, the community would look into those communities and help them a lot. And you would find that mothers are smiling, mothers are happy. So we've seen that just from, we can say, a minor intervention, huge outcomes have come out. So we believe that rectal artesunate can help malaria-affected nations like Zambia. Okay, so thank you so much.
Thank you very much. I'm going to go back a few, so actually maybe we should just pause right there. I will certainly open the floor to questions from any of you, but if you don't mind, I'm just going to ask a few questions here of the panelists. You've all talked about different aspects of the work ahead and how we make a difference. So I wonder if you could talk about the things that you think are most successful. And you've all described it from a slightly different angle. And are there things that can happen between the lab and the community and the agencies? So what would you offer as suggestions for what's working? Here you are, Joy.
I think the work that has been done in Zambia is really, like I said earlier on, sometimes the solutions are there and they're just not being implemented. And I really want to congratulate you for doing this, because ICCM and engaging the community at community level interventions like this is really what is going to make a difference in saving lives. One issue that worries me in our communities, in our countries, is the late uptake of new commodities. So you talked about you talked about the rectal and then the injectable artesunate, and the fact. But what I find really sad is that the uptake amongst our countries is very slow, and some countries take a very, very long time just to register a drug before they start using it. Even when it has been pre-qualified by WHO and when other countries are already using it. And for me, I mean, I think this is something that really needs to be accelerated. We need to find a way of working around this. And the other issue that I wanted to raise was that I wanted to comment on was we are targeting adolescent girls. But I think what we have found, I think historically is always useful, is to target both the adolescent girl and the adolescent boy, and then you get much better results. The time when Sub-Saharan Africa still is the epicenter of the HIV epidemic, but the time when we were really educating everybody about HIV/AIDS, we found that targeting both boys and girls actually produces much better results, and I'm sure we'll get the same results in this particular case with malaria if we target both the adolescent girl and the adolescent boy.
Thank you. And I think other barriers?
So I would like to say that I think that in terms of the components of successful programs that can really address some of the barriers are ones that have, where we know that there's a clear guidelines and policies that exist. But not only that, we ensure that we engage every level of the system to implement those guidelines. So and then if we take the example of something that works, that we think of addressing it at scale right from the outset and not go in with something that is demonstrated as a pilot and then we think about strategies. But if we can think about how are we going to get to scale, think about the feasibility, the cost, and the implications of incorporating that intervention into the regular programs right from the outset would be the component of successful programs. And I think from that perspective, the program that JPIGO is working with under Unitaid funding with MMV and WHO has the components. We are still early in the phase, but it's thinking about engaging communities. It's thinking about like taking the policies and then eventually influencing policies, and then looking at scale right from the beginning, and looking at what the medicine part of it as well. What will make this more easily accessible, usable, and available, and at low cost, of course.
Right.
I think the other aspect that specifically for malaria and pregnancy and others is the bringing together of the two communities, the National Malaria Control Program and the Reproductive Health Ministry of Health programs. And under malaria and pregnancy, we've been working for many years trying to make sure that these two communities are working together, and where we see that partnership exists. Like in Zambia, we've had Zambian delegation come to the RBM meetings several times, and we know that they can demonstrate that they have worked together, they form a partnership, and they can deliver on results, and it's not just one or the other.
Right. So it's a merging of areas of success, and I certainly hear you on the uptake and scale. And Ruth, do you want to add something, since everything that you're doing is working at scale?
Yeah, I'd love to add up something, especially on policies and programs.
Yes, please.
If these can be structured in such a way that they are led by the community itself, because usually the challenge comes in when you come up with a program or a policy and then you just push it into the community. It's quite difficult for them to understand it. But if you engage the community on what challenges they have and then come up with interventions that are community-led, then I believe this can really help in reducing or eradicating malaria. Because, for example, we have indoor radio spraying, mass drug administration in other countries, and then we also distribute treated ITNs. So if this could be done annually and then the community itself comes in and does them, then I believe then those community or policies or programs can work, just involving the community itself.
It's a wonderful suggestion, and I think you drove it home for us so beautifully when you were showing the demonstrations of having to communicate physically, you know, through music and through the body, etc. And it's just, I think it's an important reminder for us. It's not just a head. Solutions won't just come through the head, they'll come through the heart and through the body. Vivica, what would you say?
Well, from R&D perspective,
Yes.
we seem to be slightly disadvantaged in terms of the stories, success stories that we can tell, because, as I said, 95% of the drugs that we're trying to develop will fail, and it's hard to motivate people to keep on donating and funding R&D activities. I think partly because of that, it takes such a long time. So. In terms of suggestions and barriers that we have today, I'd like to just encourage governments to continue supporting R&D activities because it's important that innovation continues and that new tools become ultimately available, because I think despite all the efforts that we're putting into eradicating malaria, it will take time and the tools will become much more specialized towards the end. When resistance might be much bigger of an issue than even it is today.
And can I ask you a specific question? Because Cokie talked about not everything needing to be linear. Like in order to address this, we can't just do everything in a slow sequence that goes over 5 or 10 years. And you spoke so beautifully about the population of pregnant women and pregnant women in trials. Do you have 1 or 2 suggestions about what could speed up the participation and therefore the learning that would come from pregnant women?
Yes, so in accordance to the guidances that the US FDA is now starting to issue, one important step would be to incorporate pregnant women and during phase 3 development to actually start testing or comparing the doses. So this is the nonlinear thinking, that we should figure out that the dose for pregnant women is going to be the same, the effective dose is likely to be the same as for a non-pregnant population. And that saves us that time of trying to figuring that out later, sort of post-approval. So that's one seemingly small, but an important step that we're now doing today. And the other suggestion also is to go back and have a better look at the drugs that are used today, which are actually as unsafe as we think in animals. Could they be, some of them be recombined, redeployed, because it will take us a long time to develop new ones, but we can probably do much better with the ones we have today, and getting that dose for pregnant women correct would be quite important to do.
Wonderful. Can I keep going? Does anyone have a question in the audience? Yes? And then I'm going to ask a couple more questions. Please. Can you use, as we say to our children, an outside voice, a loud voice?
All right. So I have a question for Cokie and sister from Zambia. Okay. So
Oh, and we do have a microphone for you here. Thank you.
all right. So I just recently took a position in malaria. So.
Well, wonderful. Welcome to the team.
And one thing I found very interesting is when Cokie spoke about the low coverage of IPT3. I mean, if you read the WHO MAE guideline, you realize that it states that the denominator is overestimated, right? And I have issues with that because I'm just wondering why calculating for IPT3, we still use a denominator as used as IPT1. So I don't know, maybe if there should be global communication about this, because we are trying to see how best we can pilot and see, not using the global denominator as ANC registrants, but then use the specific trimester and then calculate and see how the performance is going to look like. So it might not be a question, but it's something I wanted to
It sounds like a question to me, and it sounds like a question for Cokie.
Yeah. And then my sister from Gambia, I think what you are doing is very interesting. I'm from Ghana, so, and I think we are not using bicycle but we have this motokin, tricycle from, I think it's made from China. So that's what we use. They call it ambulance at that level, or mobile ambulance. But I just wanted to be sure how these community volunteers or community health workers are able to detect malaria cases. Because sometimes you might have the symptoms, but it might not necessarily mean it's malaria. So that's what I just wanted to. And then maybe do you have the SMC program in your country?
Great. So, Ruth, why don't we start with you, and then we'll come back to Cokie.
Okay. On the community volunteers, how they're able to detect malaria. Usually during the training, we do not emphasize on actually testing and treating, waiting for a child to be tested, because from countries where we come from, like Zambia, you might find that the test kits are actually not available in most facilities. So what we've done in our training, we've actually emphasized on the signs that a community volunteer should look out for if a child has severe malaria. These are convulsions, we have fitting, we have a child who cannot eat, who cannot breastfeed. So when they look at these signs, and of course temperatures are very high, so it is easy for the health volunteer to notice these signs and then actually give recto-artesunate. And then the testing can be done at the facility. And usually from the signs that they see, we've discovered that even if a child went to the facility and gets tested, the RDT, the rapid test, would come out positive. So by just recognizing the sign and knowing the signs of severe malaria, they're able to give recto-artesunate without actually doing the testing.
Great. Yes, Cokie.
Yeah, thank you for a great question. I think that's an area that we have struggled with, but that's the standard definition that is being used by WHO at this point. And we have had meetings with the RBM Malaria and Pregnancy Working Group that is focused specifically on indicators and looking at what should be used in terms of the looking across the countries and understanding IPTP 1, 2, 3, and 4 that are measured. I think as some countries are moving towards pregnancy registers, that we might be able to follow one woman throughout her pregnancy. We might get a better sense of what is the actual uptake of IPTP throughout her pregnancy. But at this point, that's the indicator that is being used. And we do see that when we do have stockouts, that the indicator really drops substantially. So it is giving somewhat of a picture of the IPTP going down. And I think that it's important for us to consider that if we are seeing this low IPTP uptake across the countries, that we have to do something disruptive about it and not continue to say that somehow we'll be able to fix it. Because it's not happening, it's not going up in most countries unless we are now seeing with community-based uptake that it is showing some changes, and we hope to continue in that direction. But it's a really good question, and we want to make sure that we are using the standard indicator, and there's constant discussion going on about how we measure the IPTP uptake.
Thank you. Unless I see one of you put your hands up, I want to ask a couple of what I would call challenge questions. So since we know we're here and we're talking at the 20th anniversary about a future agenda for MMV, can you name one or two things for MMV to do as they're designing their forward agenda? And then I'm going to ask you about government. But let's start with MMV. Are there one or two things that you think in the agenda that's being designed for MMV that you would really like to see, and not something that's in the near term, something that you know is possible, but maybe a big dream that you've had or some idea that you've had that you think could really advance outcomes? Oh, yes, please, Joy.
I'm not
You've clearly been thinking about it.
I'm not a scientist, but I was very grateful when you talked about lactating mothers, because that would be a wonderful breakthrough. But I also wanted to find out, going back to the IPT, the preventive therapy for pregnant women, is there no way that you can develop a slow release that is injectable or something like the contraceptive? Is that a possibility for pregnant women, so that they just get it once and then it slow releases over the term?
And Joy, if I could, that's from a science point of view. Do you have, from a policy point of view, is there something that you think would be particularly helpful? I'm going to let you think about that. Cokie, how about you?
So I think I mentioned that at this point, the only drug we have for preventing malaria during pregnancy is SP. And I think that there are instances where, there's instances of rising resistance. So my hope is that we have several options for women in the long run, because we will need to have these options so that women can take those alternate drugs over time. And we recognizing how long it takes for us to develop those options for women, it would be really important for us to start investing. And there is investment. And I know that including pregnant women in trials now will really expedite and help in that process. But I think that's one area that I feel is going to be critical for us. At this point, if we see greater rise in resistance, we don't have an option for treating women in pregnancy.
Right. Vivica?
Would you like me to respond?
Well, if you like, but also, what's on your challenge list?
Oh, okay. I was taking notes for MMV. So
for your own challenge list.
Yes. Well, I think the two that were already mentioned very much fit in the topic for today. So to Joy's question, yes, we're definitely thinking about long-acting, injectable drugs. The problem with currently available antimalarials is that they're given at high doses, and we need lower doses for these slow-releasing solutions. So those are projects that are ongoing for new molecules where the potency is higher, but definitely on our radar screen. And so are alternative options to SP. So we have looked carefully through the existing antimalarials and found that piperacin and pyroneridine, which are very old antimalarials, happen to be the only two that we have in the toolbox today that do not have any untoward effects in animals on fertility, reproductive cycle, etc. So we're thinking about putting those two together, which could be done much faster, we think, than developing completely new drugs, and perhaps redeploying them in areas, particularly in East Africa, where SP is not used. So that's also on our radar screen. And as far as any other challenges, my list is very long.
It is very long. Pick one. Just pick one and share it with us.
Well, it has maybe not to do so much with science, but it's keeping our pharma partners engaged and contributing to global health and development of new antimalarials in particular. So we'd like to continue with their engagement.
Right, because I mean, with a 20-year partnership, it's going to require that level of constant innovation, constant investment, but constant innovation, because as you deal with more and more populations, that's a true statement, right?
Yes.
That would be true. So
and if I may add, I think one more thing that I don't know if it's only squarely MMV's challenge, but I think it's a challenge for us as to why we don't have a system or a process where women go into the antenatal care or work with a health provider and say, oh, you didn't give me my SP this week. Why didn't you? Where is it? I mean, the women themselves have to have the behavior change process that we need to bring about is that women demand it. And it's not only the provider that is telling her that this is what they need. But the women recognize the risk to herself and to her unborn child and say, I haven't received it, I need to get it, and you need to make sure that you give it to me.
Yes.
And that community level behavior change is something that I really hope we can bring about.
And Ruth, I think you're our expert on community level behavior change. Do you want to build on Kokie's suggestion?
Yes. There are times that I actually attended one antenatal service, and we're actually crying out to say, this month we haven't been given the antimalarial prevention, and we were told we've run out of stock. So in some areas, women would actually cry for it, but there is nothing that the health provider can give them. So I believe if there could be maybe a lot of sensitization actually helped or has helped in urban communities in Zambia to know about the 3 intakes that one should take when they are pregnant. But in the rural community, I believe if more sensitization could be done, women would know their right that they need to have that when they are pregnant.
So education, yeah. Okay, and now, oh yes, please.
One other question.
Yes.
Yeah, one other question. It's not really an MMV issue. Well, it could be, but
Ivana, it could be.
but one of the challenges that sort of operational challenges that we people are telling us about on the ground is a packaging issue. And sometimes packaging can be very, very can influence the extent to which you use a commodity. So that there are countries that are now using Actelic, and Actelic is distributed in liquid form in bottles. And because it is distributed in bottles in liquid form, they break. It's very, very difficult to transport. So for that reason, people are moving away from use of Actelic. So one thing that I wanted to find out is the extent to which MMV would be interested. I mean, Actelic is not a medicine. And this is a medicine event. It's a medicine initiative, but just is it possible to have it in powder form and then you make it liquid later on, or just trying to emphasize the importance of thinking about operational issues when you develop some of these products.
It's a very practical question. I have a feeling that's very practical, just like you, Joy. Okay, so now I think just as a final round of questions, and we'd certainly be happy to hear from also anyone in the audience, is if the Prime Minister, the Minister of Health, Minister of International Development were to walk in the door here today for Canada or in your own country, what 1 or 2 things would you like to ask them to do right away? Is there something beyond sustainable funding? I think we all understand that sustainable long-term funding is the right thing to do. But is there anything that you think that governments specifically could do? Anything else?
I think what we find in our countries is that the strategic plan that countries develop, in some countries, they don't actually, when they talk about universal coverage, they talk about meeting a certain quota that has been specified in the plan. Like if they want to do 20% this year, 40% next year, 60% the following year, then they say they have achieved universal coverage for that year. And I really want us to redefine universal coverage to mean that we have covered everybody and not that we have met the targets that are in the plan. That is the one thing that I think is wrong.
Redefine universal coverage.
Yeah, it has to be reaching everybody,
Right.
not meeting the targets that are in the plan.
Okay. Redefining universal coverage. Cokie?
So I think for me it would be, well, continuing to be coordinating with multiple donors so that we have a uniform and, coordinated approach to things. And then the second thing is to continue to fund solutions and innovations, but recognizing that innovations are not always just products or gadgets, but they're also innovations in how we deliver services or practices. And so that recognizing all of these, that we continue to invest in this and make change happen when we are not seeing progress.
So delivery across the supply chain, if you will, services.
Yeah.
Yes, wonderful. Innovation exists everywhere.
So I will stick to R&D, and I think it's a shame that the Prime Minister wasn't here for the session today, because I think
But you might bump into him in the hall. so this is your opportunity to practice right here.
Exactly, my elevator pitch.
Yes.
I think we made a compelling link between gender equity and malaria
Yes,
today.
I think you did.
And Canada really stands out in all the work that you're doing in gender equity, and we really would appreciate that link being translated into some funding for R&D activities in particular, because MMV has an extensive network, as you know, of academic and industry collaborators, and we used to have very close ties here in Canada, so we know that the expertise exists. It just needs to be reinvigorated, and I think funding would do just that.
That sounds like a great elevator pitch.
It's a bit long, but I'll work on that.
Reinvigorate the relationship. That's your elevator pitch.
Yes.
There'll be lots of. The Prime Minister will be around, as you know, starting on Tuesday. Well, actually tomorrow evening, and then so
Good.
practice up.
I shall.
Ruth, what about for you?
Coming from the community, it has to touch the community. So for me, I would love, or if he was here, to say work with already existing interventions that are working to eradicate malaria, because they know the challenges, they know the outcomes, how they can be done. So if those existing interventions are continued on for a period of time, not you start to end, then you interfere with the actual outcomes of the program. So if it could be at a longer period of time, then the actual results are achieved, then I believe that can be done and it can help the communities. Unlike shorter interventions, because like they get back to the previous way of doing things, and because there's no continuity at the end of the day.
Yes, it won't be lasting without that. Thank you for that. I think we've all been humbled by the level of experience here on the panel with us today, and I also feel very encouraged to know that this issue is in the hands of people like you. Working separately and working together. So would you join with me in thanking the panel? Ivana, No. Thank you. So thank you very much. And listen, have a wonderful Women Deliver. We have a very busy few days ahead of us. And everything you said here can be said quickly in a hallway too. So keep pitching. Yes, please.